Okay, good evening. Welcome to the WPS GHA Contractor Advisory Committee meeting. Today's date is June 26, 2025. The time is 6:04 p.m. Eastern. My name is Dr. Alhassan El-Ghosh. I'm the co-chair for the state of Indiana. I'm an otolaryngologist, and I have the pleasure of moderating this meeting with Dr. Vlahakis. The purpose of the CAC is to present the draft LCDs up for consideration and to take comments from the CAC. The public is welcome to attend in a listen-only capacity. Our disclosure requirements are as follows. Your attendance as a CAC member at this meeting implies that you consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final draft LCDs discussed. If a CAC member does not consent, please disconnect now. This meeting is being recorded and transcribed. To aid in transcription, before making any comments, please state your full name and any conflicts of interest you may or may not have. And individuals wishing to comment can raise their hand using the raised hand icon. If you're attending by phone, you can press *3. When Mr. Staley calls on you, please make sure that your microphone is on and your speakers are muted so that there's no echo. And CAC members should follow up any verbal comments that are made in writing to the email that is provided, Medicare policy comments at wpsic.com. And now I'll turn the meeting over to Dr. Vlahakis.
Thank you so much, Dr. El-Ghosh. So it's my pleasure to present the proposed LCDs. The open comment periods for these LCDs are from May 15th, 2025 until June 28th, 2025, and also from May 29th, 2025 until July 12th, 2025. The proposed LCDs are in the agenda, and the first one that I'd like to present is LCD DL 36408, which is entitled Allergy Immunology with Subcutaneous Immunotherapy. The open comment period for this LCD is from May 29th until 2025 until July 12th, 2025. This proposed revised LCD is a multi-MAC effort to create a policy consistent with current evidence. It's the responsibility of Policy Coordinator Andrea King and yours truly, CMD Joelle Vlahakis. So let me summarize. Allergy immunotherapy involves the administration of an allergen to which the patient is sensitive for the purpose of modulating the untoward immune response to that allergen and alleviating allergic symptoms. This therapy represents the only therapy capable of inducing a state of immune tolerance and provides the potential to effect a sustained clinical benefit with long-lasting clinical remission of allergic symptoms. This LCD stresses the importance of shared decision-making and the vital role allergists play in modifying factors which impact a patient's health and the quality of life. In keeping with updated guidelines, atopic dermatitis due to dust mites has been added to the covered conditions for allergy and immunotherapy. It will remain open for comment until July 12th. Now, comments will not be addressed individually, but compiled and addressed in a response to comments document posted with the final LCD. So we now open the floor to your comments on this LCD specifically. Raise your hand to request to speak. Introduce yourself, state your affiliation, and indicate whether you have a conflict of interest and what that conflict may be. If a previous speaker has made your point, but you wish to go on record, you can simply say that you agree with the previous speaker. So with that, I'd like to open it up for comment.
And those of you on a touch-tone phone, you can press *5 to raise your hand if you would like to make a comment. Otherwise, the raise hand icon is on the top of the screen.
Dr. Ford, please, you have the floor. And you may still be on mute. Rich, can you make sure that we can unmute Dr. Ford?
I got it. Can you hear me now?
Yes, thank you.
Okay. All right. I just wanted to make sure, are we going to speak about each topic of immunotherapy separately or as a whole?
As a whole,
Okay.
specific to this LCD.
Okay. Are we going to be talking about the dose of the immunotherapy?
So that's included specifically in our billing and coding article, but if you'd like to go on record, Dr. Ford, this is your opportunity.
Okay. Well, as you know, I'm a traditional allergist and in independent practice. And I've always been concerned about the 1 cc dosage. And it doesn't seem to be what any of my allergy colleagues are doing. It never has been, and I've been doing this for quite a while. And I've always wondered where that got put into that code of 95165 in the first place. Because typically at our top dose, we're only at 0.5 cc's. And is it possible that we can readjust that definition and go with the CPT code definition and not the 1 cc that we're bound to at this time?
So Dr. Ford is a very generous soul, and she's done a lot of work with the Multimac team to help create a LCD and subsequent billing and coding article that match current practice. One of the discussions Dr. Ford and I have had at some length is that embedded within the internet-only manual, specifically the claims processing manual, is language that defines the aliquots for allergy dosing. That is a hard set at 1 ml, and this is something that, for whatever reason, was written into that particular document. So I know, Dr. Ford, we've had lots of discussions about how the MACs are unable to adjust that, but that continued conversation can be had with some of the folks that you continue to network with. And I appreciate your coming on record here with your concerns that are certainly understandable concern, and as we've discovered, shared across your specialty.
And I have a second question too. Is the amount of milliliters that we can make up during a day for one person, as not only one daily making the extract up in one day, but also what they're allowed to have in 1 year. That isn't as difficult as the 1 day, particularly when they're starting on immunotherapy. You have to make dilutions from there, and that runs up into several other milliliters that put you over the top. So the dilutions are a problem, but they're absolutely necessary to do, because you cannot give the maintenance dose to a person without the buildup, or you're going to run into a lot of safety issues and with allergic reactions, including anaphylaxis.
Thank you, Dr. Ford. Appreciate that. And I think we have also talked about that the units are set at 30 medically unlikely units, and that typically for most allergists, they felt comfortable with that with the various societies and the like. But yes, I think your continued work with this Multimac group has not gone unsung, and we really appreciate it. Are there any other comments that you'd like to make?
I know that there are 40 states that have already agreed to the increase in the amount of milliliters that can be made. I was just wondering why we haven't done that in our in our max? Why? Because there are 40 states that have agreed to that. What makes that a difference?
Well, this is a multi-MAC effort, and the Medicare medical unlikely edits is set at 30, meaning that up to 30 doses can be given in a single session. And again, that seemed to be comfortable for most. And I think
that's not the doses given. This is what we can make up in the extract.
Sure.
But that's over a longer period of time, and not just one visit, of course. Okay, I will be quiet.
Thank you, Dr. Ford. Are there any questions from the CMDs, WPS CMDs?
Hello, can you hear me?
Yes.
Hi, this is Dr. Patterson. My raise hand button's not working, so I apologize. I'm an allergist in Region 5 from Indianapolis, Indiana, in private practice.
Thank you, Dr. Patterson. Please continue.
I want to concur with what Dr. Ford said, but maybe add a few things. It's my understanding from talking to our people at the college that actually the 1 cc dose that Medicare follows was never really put into law and writing. I know it's been followed, but it was never really put into writing. And I guess it's a discussion at the national level as to really what that's going to be going forward. So that's really not set in stone. And then, as Dr. Ford said, it doesn't make any sense in terms of reality, in terms of how we do dosing. When we give allergen immunotherapy, the dilution changes, the dose changes, and the interval changes frequently for our patients depending on where they're at. So 1 cc bears no relation to reality at all. And I know you all didn't set that standard, but I'm just saying that doesn't really, as Dr. Ford alluded to, that makes no sense at all in terms of if you're a practicing allergist. And so we believe strongly that we ought to be paid on the dose, not some volume, because that's always changing. And as she alluded to, Palmetto, Noridian, National Government Services, and Novitas have all agreed to changing that. That's 40 states now, so that's quite a bit. So I just would urge the committee to think about that, because this just doesn't mirror at all what we do. I don't know how it ever got started, but I know we're all working to change it, and the other MACs were very receptive to our explanation to them and to saying, yeah, this doesn't make sense, we need to change it. So not that I expect you to rubber stamp that, but I know that just like physicians talk to each other, the MACs talk to each other and say, okay, what have you done? What did you do? Why'd you do it? What's reasonable? And there's some cooperation there. And so I would encourage you to talk to your colleagues at the other MACs that I just mentioned that have already agreed to this. But
thank you, Dr. Patterson. We actually all developed it together. So the language of WPS's LCD mirrors very, very closely Noridian's, Palmetto's. We were on that work group. And I would also just mention to both you and Dr. Ford that the response to comments time is still open. And if you'd like to include those comments in writing, we're still accepting those. We actually haven't gotten very many comments, so we'd appreciate that.
Okay. Thank you. I appreciate it.
This is Dr. Ford again. Not only do we have differences in dosage as we're building to the maintenance dose, but also during maintenance, many times people will have reactions during that time, and we have to drop the dose down or move it around and drop it to half or whatever. And so the same 1 cc just doesn't make any sense, because we would never do that, particularly if there's a reaction that had been seen previously. You can't keep doing it. Can't keep giving the same ones when they react to it. So you have to drop backwards.
This is Dr. Patterson again. I might add one other thing too, to Dr. Ford. The other thing I think we should think about, because we're always thinking about this on a global perspective, both providers and the MAC, in terms of cost to consumers, cost of the healthcare system. And one of the things that I think we'd be remiss if we didn't point out is there's pretty good data, and I'll put this in my comments that I send via email, but there's data out there showing that if you put people on immunotherapy, especially children, you reduce their chance of developing asthma by like 25 to 50%. There's also data out there showing that if you put asthmatics on immunotherapy, it's essentially equivalent to being the equivalent to having them on an inhaled corticosteroid. So, you know, how many times in medicine are we preventing a chronic disease that could cost the healthcare system a lot of money? And then also we're reducing medication costs because people on immunotherapy generally are on less allergy medicine and many times less asthma medicine, have better control of their allergies and asthma. So they're not having asthma exacerbations. They're not accessing the healthcare system for allergy flares and asthma flares. So that's a considerable amount of savings to the healthcare system, and I think that needs to be emphasized.
Sure,
I
and
agree.
I think
I
you'll
agree
find
with
it's
that,
in the
Dr. Pedersen.
yeah, it's definitely within the language of the LCD. It very stresses that important and pivotal role that allergists play within the context of long-term health. Doctors, Rich, you may have to help our next person. They have a hand up, but I can't call. I only have a phone number.
Yes, I can. 773 area code. I will allow mic. You can now press *6 to unmute yourself.
Hello, it's Dr. Geis calling from Missouri. I'm an anesthesiologist and pain management expert here in Missouri. I'd like to echo the comments of the last caller in regards to immunotherapy and how it reduces asthmatic reactions, particularly important when providing anesthesiology to our patients. Thank you.
Thank you. Are there any other comments? Okay, this has been wonderful. Thank you so much to Dr. Patterson, Dr. Ford. We appreciate you stepping forward and giving us your expertise. Okay, if we're all right, I'd like to go on to our next proposed LCD. That is DL 38682, entitled Transurethral Water Jet Ablation of the Prostate. This proposed LCD is also a multi-MAC effort to update the original coverage policy. Open comment period for this LCD is from May 29th, 2025 to July 12th, 2025. This proposed LCD is the responsibility of policy coordinator, also Andrea King, and CMD, myself, Joelle Vlahakis. So as we all know, benign prostatic hypertrophy is a very common condition, and its incidence increases with age. Prostatic enlargement can lead to bothersome lower urinary tract symptoms, which can have a significant impact, as we know, on the quality of life of our beneficiaries. WPS, along with other MACs, received reconsideration requests to revise the covered indication guidelines by removing the age requirement, the prostate volume specifications determined by transrectal ultrasound, the need to avoid at least 125 cc's of urine, and the exclusion criteria of patients with known or suspected cancer, including a PSA of greater than 10, unless the patient also had a negative prostate biopsy within the last 6 months. So the multi-MAC effort also considered limitations on bladder calculi and BMI. So based on the submitted information and the searched evidence, we determined that the literature was insufficient to compel an age limitation, and that's been removed. The literature also supported removing the requirement to have a prostate volume determined by transrectal ultrasound, though the volume requirement itself is still supported. The volume voiding requirement has been removed so as not to exclude those who cannot void even small amounts. The prostate volume criteria and elevated PSA and known or suspected prostate cancer criteria were not revised, and there is insufficient data to remove the coverage limitations on bladder calculi or BMI. The coverage guidance, summary of evidence, and rationale for determination have all been revised and reformatted. So again, comments will not be addressed individually, but will be compiled and addressed in a response to comment document posted within the final LCD. So we now open the floor to your comments on this LCD specifically. Again, raise your hand to request to speak, or Rich, I think it's #3. Introduce yourself, state your affiliation, and indicate whether you have a conflict of interest and what that might be. And if a previous speaker has already made your point, as we just saw recently, so nicely, if you wish to go on record, you can simply say that you agree with the previous speaker. So with that, I'll open it up for comments.
And just it's *5, #5 if you're on a dial-in phone. Thank you. Okay, I see no raised hands.
Okay.
Nothing in the chat.
So with that, I would like to introduce my colleague, Dr. Juan Shaning. He is going to moderate this next section of our CAC meeting, and I've asked him to do that out of deference and respect for the work that he's put on this particular LCD. Dr. Shaning?
Thank you, and good evening to you all. The last proposed LCD of today's CAC engagement meeting is DL40193, titled Superficial Radiation Therapy, SRT, for the treatment of non-melanoma skin cancers. This proposed LCD is a multi-MAC effort that has been developed to create a policy consistent with current evidence for the treatment of non-melanoma skin cancers with superficial radiation therapy and address a variation of superficial radiation therapy utilizing high-resolution ultrasound guidance and electronic brachytherapy for the treatment of non-melanoma skin cancers. The proposed local coverage determination policy ensures access to superficial radiation therapy as a treatment option for non-melanoma skin cancers in non-surgical patients. The policy does not cover image guidance with ultrasound to perform SRT or electronic brachytherapy, as there is insufficient evidence to support these modalities and the evidence fails to demonstrate benefits to the patients. The position of this policy aligns with the recommendations of the American Academy of Dermatology, American College of Mohs Surgery, American Society for Radiation Oncology, and the National Comprehensive Cancer Network. The LCD requires that only appropriately trained providers must perform radiation services. It does not prohibit dermatologists from performing radiation treatment. It allows performing providers with experience and training necessary to deliver SRT in a safe manner and in compliance with all current guidelines for radiation therapy. This LCD is the responsibility of Policy Coordinator Michelle McCarty, and I am the responsible CMD. And this LCD will remain open until June 28th. So, as Dr. Barajaca stated, please send your comments in writing. We value them, and we will address them in our comment response document. So any comments that you have on this meeting, you can send also in writing, as well as any comments that you consider after this meeting. So today, we are going to have two formal presentations on this subject matter. So I will take the comments in general after the two formal presentations from all of the members that are attending this meeting. So our first formal presentation is from Dr. Timothy Hansen. He's one of our CAP members, and he's representing American Academy of Dermatology. So Dr. Hansen, please state any conflict of interest and proceed with your presentation.
Thank you. Thank you. Can everybody hear me?
I can hear you well.
Okay.
Thank you.
Thank you. My name's Timothy Hansen. As he said, I'm a board certified dermatologist and the Iowa dermatology representative for the J5 CAC, as well as the Iowa representative to the Derm CAC, which is a national coalition of dermatologist representatives selected by state dermatology societies. I have no conflicts of interest to disclose. If you could please advance to the next slide. The Derm CAC appreciates this opportunity to provide comments on this proposed LCD. In particular, our comments focus on two key messages. First, we support this proposed LCD's coverage of SRT as secondary treatment for non-melanoma skin cancer when surgical intervention is contraindicated or declined. And second, we support inclusion of dermatologists as qualified to furnish SRT for non-melanoma skin cancer, but we recommend changes to the requirements for demonstrating training and expertise, a slight change in wording compared to what the proposed LCD has, in order to preserve patient access to qualified, appropriately trained dermatologists. I'll provide additional details on these messages in my comments today. Next slide, please. So starting with our support for SRT as a secondary treatment option, this approach is consistent with current available evidence and specialty society guidelines, including the American Academy of Dermatology clinical guidelines. These guidelines recognize that surgery is the most effective treatment for basal cell carcinoma and squamous cell carcinoma, with very few exceptions. We note that surgical options like excision and Mohs surgery are safe and well tolerated, even among high-risk populations, including elderly, immunosuppressed, and medically complex patients. And as a result, non-surgical candidates represent a small subset of the overall skin cancer population. At the same time, the evidence reflects that SRT is reasonable and necessary in select cases, thereby supporting coverage as a secondary treatment option. We appreciate that WPS has conducted this comprehensive review of available literature. We support these coverage decisions and that reflect the current state of clinical evidence, but also encourage continued reliance on the best available data as WPS finalizes this LCD, as well as when considering potential future policy updates. The next slide, please. We appreciate the proposed policy recognizes the importance of patient selection, clinical judgment, and shared decision-making in the treatment of non-melanoma skin cancer. And so it allows physicians to exercise autonomous clinical decision-making authority to address individual patient care needs. To that end, we appreciate the inclusion of language outlining examples of clinical scenarios that may qualify a patient as a non-surgical candidate, such as potential functional impairment, significant morbidity, or poor cosmesis in anatomically sensitive areas, as well as situations in which patients decline surgery following shared decision-making. We highlight the importance of physicians collaborating with patients to consider factors such as cure rates, long-term clinical outcomes, maintenance of normal anatomy and function, medical circumstances, and patient preferences in deciding a course of treatment. We also underscore the importance of discussing potential risks and benefits with patients before moving forward with any treatment approach, and appreciate that this policy supports SRT as an option in the treatment against non-melanoma skin cancer. Next slide, please. Before I continue, I also want to address the policy regarding high-resolution ultrasound and image-guided superficial radiation therapy. The LCD does state the use of high-resolution ultrasound to guide SRT delivery and assess lesion reduction during superficial radiation treatment protocols not considered reasonable and necessary and not supported by literature. We acknowledge that this is still an emerging area of technology. However, the current published evidence does not allow definitive determination of the value of image guidance during a course of SRT. So more evidence and scientific literature is needed to apply the best available high quality data for future policy updates. Next slide, please. As I previously mentioned, the Derm CAC also supports inclusion of dermatologists as qualified physicians to perform SRT for the treatment of non-melanoma skin cancer. We believe this policy, as proposed, reflects dermatologists' longstanding expertise in diagnosing and treating skin cancers, including their comprehensive understanding of skin anatomy, oncology, which they've gained through residency and fellowship training, as well as through ongoing clinical experience and continuing medical education. Dermatologists have also led in the study, knowledge, and use of superficial radiation and electromagnetic energy across a various variety of wavelengths to effectively treat a wide range of skin conditions. Dermatologists have a long history of furnishing superficial radiation therapy under the Medicare program, with Medicare claims data demonstrating that the majority of SRT services for non-melanoma skin cancer are furnished by dermatologists. So we highlight that the inclusion of dermatologists as qualified to furnish SRT supports patient access, continuity of care, and positive outcomes. For example, this approach allows for streamlining of diagnosis, treatment, and follow-up within a single office under a dermatologist management, rather than requiring referrals and coordination with other treatment facilities after the dermatologist diagnoses the cancer. As a result, it minimizes handoffs and opportunities for delay or misunderstandings. Finally, by allowing dermatologists to furnish SRT, the proposed policy establishes a broader pool of qualified physicians able to furnish SRT. Restricting dermatologists from performing SRT could create barriers to care and limit access to timely, cost-effective treatment for patients with non-melanoma skin cancers. Next slide, please. And now at the same time, we are concerned that the proposed policy requires dermatologist training and expertise to have been acquired within the framework of an accredited residency or fellowship program. And we believe this approach is flawed for numerous reasons. First of all, it unnecessarily excludes qualified dermatologists, restricting patient access to medically necessary care, and doesn't reflect current clinical practice, as many dermatologists completed residencies or fellowships before the emergence of these newer SRT technologies. And so it fails to recognize alternative avenues for receiving training and developing expertise that dermatologists pursue, including continuing medical education, postgraduate training programs, hands-on experience, for example. So if all clinical services were limited to what physicians learned as part of their residencies or fellowships, the ability to innovate and offer advanced treatments would be severely crippled. Next slide, please. So for these reasons, the Derm CAC recommends that WPS finalize coverage of SRT as a secondary treatment option for patients when the surgery is contraindicated or declined, finalize inclusion of dermatologists as qualified physicians eligible to furnish SRT, and revise the training and expertise requirements that apply to dermatologists to acknowledge that the appropriate training and expertise may be obtained through multiple pathways outside of residency and fellowship, including CME, postgraduate training programs, and hands-on experience. I appreciate your considering these comments, and I'm happy to answer any other questions that may have come up.
Yep. Thank you for your presentation. It's greatly appreciated. As mentioned, this LCD is going to be open for comments until June 28th. As part of your comments, it would be appreciated if you could send verbiage that you feel captures the proper training that supports what a dermatologist that are qualified to provide the services should have. What's the verbiage that you consider should be adjusted on the LCD. That's always helpful when we receive that kind of information on the as a comment, and we will address on the comment response document. Since we have another presenter, I will go to the next presenter, and after that presenter, I will take comments as a whole of the group, okay? Thank you. So our next presenter is Dr. Erin Garner. He's a guest speaker from the American College of Mohs Surgery. So Dr. Garner, please go ahead, state any conflict of interest, and proceed with your presentation.
Yes, thank you. Can you hear me?
I can hear you loud and clear.
Excellent, thank you. Yes, so I'm Erin Gardner. I represent the American College of Mohs Surgery. I'm a board certified dermatologist and Mohs surgeon in Missouri and St. Louis. And I am here to express our support for the proposed LCD generally as written. My colleague, I believe from Iowa, made many good points, so my presentation I think that we can maybe more rapidly go through my presentation. So yes, we do support most of the LCD as written. I do want to make a few additional points, especially about the image guided SRT and its general lack of inclusion in this LCD. So the next slide, please. All right, so I just want to make a distinction. I'll start with this article from the Journal of the American Academy of Dermatology. It's one of our flagship journals. It reviewed the utilization of the codes used for SRT and image-guided SRT. It came out in the latter half of 2024. And so I just want to point out that this is a journal with the highest impact factor in dermatology. It has high peer review standards. It is not a pay-to-play journal. So that is in contrast to the most all of the observations, the papers that have been published on image-guided SRT. So if we can move to not the next slide, but the slide after that, here is a table that shows the utilization from that JAD article, and I'll have you focus your attention on the last two columns. The last column shows the p-value for the various SRT services that were reviewed in this paper, and you can see that there is significance obtained on most all of the CPT codes that were reviewed here. I'll have you now move back to the second to the last column, and this shows the increase in utilization from 2016 to 2021. Which is the last year for which complete data was available. And what you can see here is that SRT service utilization did increase over that time, but it drastically increased for the image-guided ultrasound guided SRT. And I think that in part is the impetus for this LCD for SRT and image-guided SRT. Next slide. As my colleague pointed out, the comprehensive literature review showed that SRT is not first-line therapy, but an important therapy to have in the armamentarium. It also demonstrated that image-guided SRT is no better than standard SRT. Let's move on now to the next slide. And the next slide. Keep going. And now back to the high-resolution ultrasound. And I believe my colleague also had a slide that reproduced the language from the proposed LCD. And what it basically indicates is that the high-resolution ultrasound for SRT, to guide SRT delivery, is not considered reasonable and necessary and is not supported by the literature. And that, in fact, is the main reason that we are here, that I'm here presenting tonight, because we believe that the proposed LCD does in fact get it right. The proponents of image-guided ultrasound, next slide, do cite several forms of evidence. And they make claims that image-guided SRT is superior to SRT, that image-guided SRT is superior even to surgery, and image-guided SRT should be first-line therapy. But in reviewing that, a critical appraisal of the published literature shows that none of these claims are supported. And specifically, next slide, when you do review the papers that address image-guided SRT, you'll find that there are no direct head-to-head studies between image-guided and regular SRT, that many of the authors are industry conflicted or the studies are funded by industry. There are no prospective randomized controlled blinded trials comparing image-guided SRT with either standard SRT or surgery. Most of these are printed in pay-to-published journals. They have poorly or non-matched controls. They are not blinded, and there is scant reporting of adverse events. One very important aspect of most all of these studies is that a tremendous number of patients are lost to follow-up. There's one study, and I'll reference here, it's specifically here in just a moment, that has 85% of tumors lost to follow-up at 4 years, and then almost 99% lost at, I believe it was 5 years. So in summary, they are not, most all of these studies are not prospective, not randomized, not controlled, and not blinded. Next slide. Thank you. And this is just a summary of the same 0 randomized, 0 prospective, 0 with a control group, 0 with a blinded central review. Let's move on now and talk about, with the next slide, the first paper that I'll specifically reference. And it's a review using image-guided SRT for the treatment of non-melanoma skin cancer. The same problem exists for this study. So industry conflicted, it's not randomized, not prospective, no control group. And only 45% of tumors had 12 months or follow-up. Excuse me, 45% of tumors had less than 12 months of follow-up. Let's move to the next slide. Another study, they had quite a large number of patients, but if you look at the lost to follow-up or dropout, at 2 years, it was 60%, 4 years, 85%, and at 6 years, it was 98%. The same problems plagued this study, not randomized, not prospective, no control group. It was a retrospective chart review. Next slide. A third study published in a journal called Dermato. This was also a study, treatment of non-melanoma skin cancer with image-guided superficial radiation therapy. And the claim was that daily measurement with ultrasound provided a benefit to the patient. But in fact, they can't, with this uncontrolled, non-randomized, non-blinded study, prove that daily ultrasound measurements actually provided an improvement or a benefit for the same reason that existed with the studies I just mentioned. It wasn't randomized, it wasn't prospective, it wasn't controlled. Next slide. When aiming to attempt to explain the image-guided findings, it wasn't clear exactly, their data did not support the conclusions that they drew. It was equally plausible that the changes in the ultrasound findings with the image-guided analysis were the result of simply tumor edema as a result of the radiation damage to the cells. So, next slide. What we find is that high quality studies comparing SRT and image-guided SRT simply do not exist at the present time. And it's for that reason, next slide, that it appears that though it may be promising for the future, it looks like that image-guided SRT could only be considered experimental at this time. And it's for that reason that we believe that the proposed LCD is right on target. And next slide. There has been this significant increase in utilization. We think that, and next slide, and next slide, some of this is just review. Keep going, 2 more slides. We believe that this, no, back 1 slide, sorry. We believe that this proposed LCD for the conscientious provider is exactly what is needed to appropriately treat the sort of skin cancer for which SRT is the best, or the best targeted. Next slide. And we believe that it will not restrict SRT treatment, but in fact, again, target this to the appropriate tumor and patient. And for that reason, ACMS does fully endorse the LCD as written.
Thank you so much. We greatly appreciate your very detailed presentation going over the evidence. It's greatly appreciated, and the endorsement of the society is greatly appreciated. So thank you for your excellent presentation. Now I will open the LCD for comments from anyone. Please raise your hand and you will be called.
And Dr. Shaning, we have a couple of questions in the chat. Would you like me to start there?
Yes, please.
All right, so Dr. Joe Moscato asked, do dermatologists who use SRT have radiation safety officers associated with their offices?
That's an excellent question. The LCD states that the expectation is that the superficial radiation therapy will be provided on according to standards of the industry of radiation therapy. We don't go into details of what's that personnel. So, but we will appreciate that question sent as a comment so we can review, and any dermatologist in this meeting is welcome to provide feedback regarding that question, but we will certainly address that question as part of our common response document, but I will appreciate if you send it in writing to the mailbox that we put on the meeting. Okay, hearing none, what's the other question, Dr. Bahakas?
So Mr. Mike Bowl has asked, what's driving the use of image guidance?
I think I can.
Okay, go ahead.
Yeah, sure. Well, I don't have a crystal ball, but I do know that the reimbursement for the codes used for image guidance is probably one factor that has to do with it. I think that there's the possibility that that in the future it might be shown that there's some benefit, but at this point there are no studies at all to indicate that there's any benefit compared to standard SRT and surgery as well.
Thank you.
I would also comment that some of the newer systems that have been produced in recent years that deliver SRT also have a component of image guidance kind of built into the system that is sold to them. And so it's kind of sold as a package deal and promoted to be used together in some of these newer systems, is my understanding. So that might also contribute to the increased use.
Thank you. Any other questions or comments? I don't see any more hands raised or don't hear any comments, so I'm giving the meeting back to Dr. Barajas. Joel, please.
Thank you very much, Dr. Shaining. And I'm going to turn it over to my co-chair as we transition to the members only portion.